It's called No Name. It's not there. Just going to add some new willy photos.
Maybe I'll it's been a while since I've tried to focus. It should be there.
Just try to pull it out and put it back in again. This is when you'll be cross that I didn't send it to you.
The less willies on my laptop, the better.
It's funny, I am the opposite.
I know.
It's not coming on there. Should we try? Right, I have far too many slides. Don't worry, I'm not going to spend too much time on 85 slides, but I just thought we'd kind of touch on everything in terms of what we can offer in the andrological service, because what I want you to know is what's available for your patients. I'm not expecting you to do any of this stuff, but it's knowing to ask the questions and then knowing that we can speak about these things. So my clinics tend to be, if you were a fly on the wall, you might think initially quite an awkward conversation. People walk in and I ask all sorts of very bizarre questions, but you have to get used to talking to men about their erections, asking about ejaculatory dysfunction, fertility, libido, chronic health, body issues, and a lot of psychosexual issues as well. I have another degree in psychology, which everyone laughed at me when I was going into surgery and I did a psychology degree, but actually I use it more than my surgical degree in my clinic, so it's very important to be able to touch on. We can go past all this, you all know more about this than I do, but in terms of our sickle cell presentation, so we know that men with sickle cell have a higher chance of hypogonadism, and the prevalence is around 25% as opposed to 6 to 12% in the normal population. They will suffer with erectile dysfunction, and that can be because of priapism history or in addition to problems with fertility. I think I've deleted a slide. The testosterone that we need to think about, so why have they got a lower testosterone? Is it a problem with the oxidative stress? Is it because of the vaso-occlusive events? Or is it because of the iron overload in the thalassemia patients? So all things to why are these men having problems with their testosterone and what can we do about it? In addition to a whole range of increased risks of endocrinology problems, things that we need to think about, such as diabetes, which will cause increased problems with erections, whether they've got thyroid problems, problems with their bone, adrenal insufficiency, and hypogonadism. So when I'm approaching a man with a low testosterone, I want to know what's the cause. Is it a problem with his testicles? So is it primary hypogonadism, or is it a problem with his brain not producing? This is nothing in terms of photos of some of the shocked faces. In terms of, is there a problem with them producing the hormones to stimulate the testicles to produce testosterone and sperm? Going back to my medical school days, so when we're looking at the brain and the pituitary, it's producing two hormones, LH and FSH. So when you're doing your blood tests, and I apologise if this is all far too basic, but we want to see, is there a problem with the production of LH and FSH? Is it really low? So if someone has a low testosterone or a problem with their sperm, their brain should be picking it up and pouring out those hormones. You would expect to see really high levels if someone's got problems with their testosterone or sperm. And if it's not that way, then it's a problem with the brain and the pituitary not producing the hormones. And so hypogonadism, primary or secondary, can be a number of different causes, so congenital or acquired causes. And what we're looking for is there a low testosterone with a normal high raised FSH and LH, which is what your brain is picking up, there's a problem and pulling out, or secondary in that it's a problem with the pituitary. So when it comes to kind of the diagnosis of hypogonadism, what you want to do, the first thing to say is men's testosterone is always highest in the morning. So if someone comes to me with a testosterone that's been taken in the afternoon, I throw it in the bin. Don't bother. So your blood test must be done first thing in the morning, so before 10 o'clock in the morning, and fasting. And the levels that we're looking at is preferably you'd like men to have testosterone levels above 12. If the level is between 8 and 12 and they have symptoms of hypogonadism, so poor libido, erectile dysfunction, struggling to put on muscle mass, or just feeling tired, fatigued, well, I kind of think 21st century symptoms for all of us. But if they're between 8 and 12 and those symptoms, I'd consider treating. Below 8 we treat, and above 12 we talk to them about a number of different things that might be causing some of their other symptoms. So when I see men who come in with a low testosterone who want to start testosterone supplementation, what can we offer? So you have gels and you have injections. And the injections can be every 3 weeks or every 3 months. It kind of depends on their GP and what the GP is willing to pay for. The 3-monthly one, which you think is much easier because it's one injection, they can forget about it, is more expensive. And so the GPs don't really like giving it. So it tends to be the 3-weekly one, which has to be administered in the GP practice, which is a bit of a pain. I like starting out with the gels. I think the gels are really nice because you can kind of manipulate the dosage quite easily in the first few weeks. And so you're sort of trying to fiddle around with what level makes them feel comfortable, in addition to looking at their blood, all their other tests that we're looking at to see how is that working. Some men will complain that they don't like putting on the gel every day. So we say to them, like, get up in the morning, have a shower, and then you put the gel on the back of your arm, and then you put your top on immediately. Don't put the gel on and have a roll around in bed with your partner. Obviously, we don't want the testosterone going into your partner or your children. Once it's soaked in, so after an hour or two, then it's fine. Some men will find that the site gets a little bit irritated, or they don't like the consistency. They'll complain of the gel, it's sticky, I don't like it, and so we'll move them on to the injections. So Sustanon is the 3-weekly one. Remember, it contains peanut oil, so you need to ask about peanut allergies. And then the long age, which is Libido, every 3 months. They tend to peak the libido at 7 days, so you have quite a high peak and then a slowly down, whereas obviously the gel, you're hopefully sort of stimulating or simulating what normal male response will be. So I will often try men on a number of different scripts before we get to the right, what worked well for you. Everyone is different. Different men might forget or not be very good about putting on creams or doing something every day. So again, if memory issues are a problem, then you might find that the injections are better used as well. But it's important to remember, if you give a man exogenous testosterone, he will stop producing sperm, or the numbers of sperm will go right down to almost nil. And so a lot of people don't know that. They start men on testosterone, and then they can get a little bit of a shock when they say, well, we can't get pregnant, but we're a bit on testosterone. So just remember, men who you're going to start on testosterone, it's going to have a massive effect on their fertility. So not only will it decrease the number, but it will decrease the motility, so how fast they're moving forward, what they look like in the morphology, and some men will complain that their ejaculated volume will decrease. And so when you're going to offer these treatments to your patients, either any kind of haemoglobinopathy, you need to think about how old they are and what is this going to do with their fertility. We know that the treatments for just different types of sickle cell can have an effect on fertility, so we've already talked about the hydroxyurea. We tend to say to men, because it takes 3 months to make a sperm, if they're on that treatment and they want to get pregnant, we would want them to be off the treatment for a minimum of 3 months, and you may consider sperm cryopreservation for someone before they go onto that treatment. Now, in terms of sperm cryopreservation, it's important to find out what your funding is in your hospital, and everyone's funding is different. So in general, if someone was to freeze sperm, they would have to pay for it every year until it's used, and it's roughly about £350 or so. Now, we're lucky at UCH, we don't have to pay for it. Are there any other hospitals here that you know whether your patients have to pay for it?
Whitkinson's free as well.
It's very variable. There's no rhyme or reason, but it's worth discussing with your patients, because obviously if you're going to do it really early in a young person and they're not going to have children for 15 or 20 years, that can have a significant cost implication for them. Ben's gone into all of the treatment effects already of some of your treatments of chemotherapy and bone marrow transplant, where we know that men might end up infertile afterwards, and how important it is to think about fertility preservation in your patients. Now, the rate of the patients who have infertility with the bone marrow transplants, it all depends on the chemotherapy agents beforehand, as well as there being a degree of variability. So I will see men who have had very high doses of chemotherapy, who I would imagine are going to be infertile, who we find sperm in the ejaculate, and vice versa, men who we would have considered to have fertility but be azoospermic and have no sperm, and it's an absolute disaster for these men. So I always say, look, freeze the sperm. We can always check afterwards, and if there's sperm in the ejaculate, then throw it away. It's much better to have options. In terms of if you were going to give a man testosterone, or you wanted to give him testosterone but not make him infertile, what other options can you do? And that is HCG injections. And these injections are injections that the patient will give themselves twice a week into the tummy, and so they need to be sort of fairly confident with needles, not too scared. Sometimes partners or mothers will give it, but it means that will push up the testosterone and retain their fertility. So that's very important for some young people who want to start trying for children, and that's in our European guidelines of urology of this is what is recommended for men who want to remain fertile. But as we spoke before, there's a whole different range of ages there of who has got sperm in their body, and so obviously you, as a woman, you are born with all of the eggs in your ovaries, but as a man you only start producing sperm once you've gone through puberty. And so what are we going to do? These are all my thousands of children, not the big one at the bottom, but at different ages is going to make you think about different things in terms of fertility preservation. So obviously if they're post-pubertal and they can produce a sample of sperm, it's really easy, but what are we doing for younger children that are going to need treatment who are not making sperm? And again, so we rely on our oncology and our hematology specialists to kind of give us an indication of the treatment and how they might be related with fertility, and the risks that they're going to have. And we can think about testicular shielding if patients are going to have any kind of radiotherapy. We can think about getting sperm if they're older, but now we're considering more and more the possibility of testicular stem cell freezing, which is an option for boys. We're already doing it for girls, and they've produced babies with this. And the male model, it's still animal model, it's still research-based, but we're hoping within the next 3 to 4 years this will be available in humans. And so if we have a young child now who we're going to take a stem cell biopsy from, we're hoping that by the time they're thinking about fertility, we'll have that research in practice. So what if you're looking at a younger person who is post-pubertal but is not able to masturbate and produce a sample, and that can be because of their age. They might not be comfortable masturbating. Now, the one thing we don't want to do, and when I started my job here, young boys were being taken down to the laboratory with their father and taught how to masturbate. We really want to try and stay away from that. We know that once you start going through puberty and you start masturbating, it can take 6 months or so to get sperm into the ejaculate. So your one-off down the lab when you've never done it before is not going to be particularly successful, and you're likely to cause quite a lot of psychosexual issues for that child and probably the father as well. So we try and stay away from that as much as possible. If someone is really poorly but they're struggling with erectile dysfunction, remember Viagra. It's a brilliant drug. If I could give it to most men out there, I would. I will often say to the people in the wards, look, just 100 milligrams of Viagra, which is the maximum dose. They need to take it an hour before they're going to produce the sample, and they take it on an empty stomach. So just remember they need to have no food in the stomach, and that works very well for people who are feeling really poorly, under the weather, and just say, oh, I just don't think I can get an erection. There's lots of things we can do to help. There might be religious reasons where they can't masturbate and produce samples, and I'll often have to talk with the rabbi or the imam or various religious leaders to get the ability to say to the patient, you are allowed to masturbate, because often they are masturbating, but once it becomes open to the world, there'll be a very quick, no, I've never done this before. So we can get involved with the religious leaders to try and allow that to happen. And then if not, so electroejaculation is a procedure that we can carry out in theatre at the same time as our bone marrow biopsies, at the same time as patients having a PICC line. It's really quick, it takes about 10 or 15 minutes, tends to make the haematologist really happy because there's no cut anywhere, so the risk of any kind of infection or bleeding is minimal. So I can go into theatre at the same time, and what I do is I take my little machine, This is my little machine, which looks like it's the oldest thing in the world, but it's actually the most modern version out there. We have to do it while the patient is asleep because it's painful. The probe is put into their back passage, 10 or 15 stimulations of the sympathetic nerves around their prostate, and they ejaculate very quickly, and we can get samples very easily. So it's a really nice tool to have. And you just need to remember that we have that at UCH. We're one of the only hospitals in the whole of the country that has it, so we should be using it. I will often have the embryologist in theatre with me, and so they will look at the sample, look at the sperm, say yes or no, we're happy. If they're not happy, then we'll go to a testicle biopsy. So this makes the haematologist and oncologist a little bit unhappy in terms of the concern for risk of someone who's about to have chemotherapy, and then I'm going to do a biopsy of their testicle. What if we have an infection? What if we have a bleed and they can't have their treatment? So we've been doing this for 4 years and we haven't had to delay one person so far. So we make sure that this is a very safe procedure. So we take a tiny little biopsy of the testicle, and we can normally get enough sperm in a post-pubertal man from a biopsy like that to have at least 6 or 7 IVF cycles. Very quick and easy. And you know, we have the ability with the embryologist and with our free cryopreservation at UCLH where it's economical for the patients as well. You need to know about that. So moving on from fertility to erectile dysfunction. So priapism, and priapism is a massive risk for our sickle cell patients, and it can be, you know, a real detriment to their life, particularly for younger patients. And so what is a priapism? And it's an unwanted, so it's got to be unwanted erection lasting for more than 4 hours, and it tends to be very painful, and it persists after masturbation, after sexual intercourse. And there's a number of different reasons why you can have it, but we're concentrating on the hematological causes now. And we know that in terms of sickle cell patients, it's very common. So sickle cell is the main cause of the patients who I see with priapism, the reason why they have it. And it tends to happen as they're going through puberty and in younger age, and it's a really miserable thing to have and can really alter their psychological view about sex and erection and masturbation. This was a small study, only 130 patients patients with sickle cell, and actually they found that 52% of patients were having this priapism in an acute situation, 72% stuttering, so stuttering up and down and up and down. And so we'll often say to the patients, so they'll wake up in the night with a painful erection, get up and exercise, and it's the most important thing to know to your patients. At UCH we have a lot of stairs. It should be the first thing. Anyone who's got any problem with a priapism, say to them, please try and walk up and down 4 or 5 times. It will very quickly bring the erection down. And actually I think we forget that very often, and patients are put into A&E and put into theatre far too quickly, and if we sent them off to do some exercising, very often, particularly the sickle cell group, we can get the priapism down. Problem is if they're unwell, by making them walk up and down a lot of stairs, you know, there's some sickle cell patients who are quite poorly to have to go through that. We also know if they are suffering with recurrent priapism, that they will start struggling with erectile dysfunction, so they will not be able to get erections when they want to have intercourse. So precipitating factors, as with much of sickle cell, so you know, whether they're very cold, if they've been unwell, if they're dehydrated, and of course if they've had quite a lot of sexual stimulation as well, but in general it happens during sleep. And so there are a number of treatments of just in terms of getting their sickle cell treated and managed appropriately will settle it down. We will often lean on you guys for the red cell exchange, so if we're really struggling trying to get someone's priapism down before we take them to theatre, we'll consider an exchange. We'll try and get them to avoid drugs, alcohol, marijuana as well. We know that marijuana and some of the antipsychotics have a really negative effect with priapism. But obviously if someone is on mental health medication that's causing priapism and they have sickle cell, we're all in a really difficult situation, because you can't stop those mental health meds. And it can make a lot of patients want to stop the mental health meds because they know that this is making it worse. So we work with a psychiatrist to try different medications to see if we can try and limit it. Improving oxygenation at sleep, and CPAP is something that we use with not necessarily our sickle cell patients, but CPAP has been used to help sleep painful nighttime erections very successfully. We also try and modulate the response to erection. So this seems sort of not intuitive, but actually some patients will start to benefit from taking drugs like Viagra as a treatment. And what we're trying to do there is modify the nitrogen oxide response to the erections. There are other drugs such as cypertonic acetate and finasteride, which are really heavy going drugs which will drop their testosterone, which again pretty miserable for a young person. but they might take that rather than being woken up every night with lots of painful erections. So what do we do when someone walks into hospital with a priapism? As I said, the first thing, get them on the steps, get them to walk up and down, get them oxygenated, check their bloods, make sure that they are optimized as well as they can be from the hematological point of view. If that's not possible, we will then do a penile block. And penile blocks are initially pretty uncomfortable, but it will make them quite comfortable. And that involves a penile block where we put quite a big needle just along the top of the penis, and we inject local anaesthetic and make the penis quite numb. And for some men, that will cause detumescence straight away. We then use aspiration and phenylephrine injections to try and reduce the erection. And that has a risk of hematoma and pain and discomfort, but it's very effective if we catch men in the really early stages. And the sickle cell patients need to be told, look, if you get these, you need to come to us early. The longer you wait to present to A&E, the harder it is to get the erection down. So there are many different ways of preparing the phenylephrine. It can cause quite significant hypertensive episodes, so we tend to do it in resus, or we do it with some form of some form of blood pressure monitoring. And obviously, if they start becoming hypertensive, then we need to abandon and stop, and they'd be taken to theatre. So if the phenylephrine doesn't work, if the oxygenation, everything else doesn't work, the next step is to take them to theatre. And what we're trying to do in theatre is to create a shunt between the arteries and the veins to decrease the blood that's trapped inside the penis. It looks like a fairly, well, it is quite a horrific procedure for a patient to go through, but they are asleep. It's a general anaesthetic. We get a scalpel. They normally have a catheter in. This patient doesn't, but they normally have a catheter in to try and minimise the injury to the urethra. A knife is put from the head of the glands all the way down into the corporal body. We turn it at 180 degrees, and that will normally fistulate between the arteries and the veins, and everything will settle down quite quickly. We need to push out all the old blood, and we often will need to do it from both sides, and then we'll aspirate and wash out of it as much as we can. I tend to find these patients lose their erection quite quickly, but quite often by the time that they are waking up, they're going back up again. So it's something that we do in theatre with really careful monitoring to make sure that it's worked and it's been successful. If it's not working, we will then take what we call a dilator, where we take a metal dilator from the top of the penis and put it all the way through the penis, tunneling all the way down. You can imagine what destruction we're causing on the erectile function here. So if we can try and capture patients before we get to that point, we can increase the chance of them getting normal erections after the procedure. And so this is a time frame where you can see the longer the time goes on that the patients present to us, the less likely it is to work. So we know if we can get them in the first 24 hours, our success rate is right up there, above sort of 60%. But between 48 and 72 hours, the chance of success is really low. And after 72 hours, that shunt is not going to work. There is nothing we can do. The muscle in the penis is fibrotic and dead. And so we tend to not to take them into theatre at that point. What we would plan in that group of patients is to put a penile implant straight into their penis. So we wouldn't go through any of the other procedures, because then they have risks of infection and various other problems which are much higher. So we talk to the patients then about having a penile implant put in. So anyone who comes with an erection that's been lasted for more than 72 hours would be counselled for a penile implant. And you can see the patients who are counselled early and implants put in early, so that's in the first few weeks, the satisfaction rates are right up at 96%. If we delay and we put the implant in months down the line, where the penis is very fibrosed, they get shrinkage, there's a lot of unhappiness with the cosmetic effect, and the success rate is right down. So although putting a penile implant is a really big thing to do to a man, the satisfaction rates are very high. So this is our algorithm, the British Urological Association. So you can see it all comes down to time and how long the patient has had the priapism as to whether we're going to do an aspiration, take them to theatre for a shunt, or go straight to penile implant. We have 2 urology CNSs available at UCH, and in fact most of the other bigger units have a urology CNS as well. They'll go to the patients in A&E, we'll show them an implant, we will try and counsel them. In a normal situation with a man who hasn't had a priapism, this takes months of careful conversation, documentation, making sure that they're happy that we're making the right decision. We just don't have that time in these groups, knowing that the quicker we do it, the better the outcome. It's not ideal, but there really is very little else we can do apart from try and support them as much as possible without counselling and knowing that, discussion as much as they need. So stuttering, priapism and nighttime erections or painful nighttime erections, it's important to get the patients educated. As we've said, we'll often ask them to try and keep a diary of some sort so we can see, is it going through a crescendo, or things getting worse and worse, in which case we'll lean on haematology. Is there something we can be doing in terms of changing their medication to try and improve things? Simple medications such as Sudafed, so the Sudafed that you can use if you, well, I don't think you're allowed to use it anymore for a blocked nose, so they take it off the pharmacy, but Sudafed before bedtime, waking up with a priapism and doing 100 sit-ups so they get a lovely six-pack at the same time as getting their erection down. And then other medications such as baclofen is more useful, less for sickle cell patients, but more for other priapism causes. And then, as I said, CPA, which is the drug that we would give to someone if they had prostate cancer and we wanted to take away all their testosterone. It's a really extreme measurement, which we prefer not to. How am I going for time?
Okay.
Yeah. So different drug options that we talked about. So epinephrine, so that comes in and out in terms of availability. So sometimes we can get it from pharmacy and other times we can't, and that works really well for some patients. If they've come in with an episode of priapism that's taken a little while to sort out, we'll try and send them home with epinephrine. Potentially also the CPA for a short period of time. So we'll say, look, we'll do this for 1 to 2 weeks and then we'll gradually decrease the dosage and get your testosterone up again. And as I said, a regular PD5 inhibitor, which is a Viagra tablet, can be very helpful as well. When it comes to any form of sexual dysfunction with men, there's always a number of different things that we need to think about. And as I mentioned, talking to them about the psychosexual side of things, particularly if they have a chronic illness, is important. They need to understand that whether they have a physiological, pathological problem with the penis or not, their brain will be involved. And so the minute men start worrying about their erection when they're going to go to bed with a new partner, they'll be thinking, am I going to get an erection? Is it hard enough? Is it firm enough? Will I get it? They start to release adrenaline and they will then start to have problems getting their erection. And that's why the oral medications we have for erectile dysfunction is so important, and one that we all need to be encouraging men to take and not having any kind of shame around taking. So I thought I'd just kind of mention very briefly in terms of when I have a man in clinic who comes to see me with erectile dysfunction, how we assess them. So I normally say, look, if you think about your erection on a score from 0 to 4, with 4 being as hard as it was when you were 18, and that is basically firm enough for penetration, to 0 being nothing, where are you? And if you had a little marker in your mind and you could put a note in your notes, so this is where they are in terms of erections, it gives you a good idea of where you're based and where you can try and get to. We have excellent questionnaires as well. So we have questionnaires which I'm very happy to send to anyone, which is quite easy to give to someone in the waiting room. It then means it starts that conversation going. So you can give them the questionnaire, they come in, and then you can very quickly go to it and say, I see that you're having problems with this or that. It's a really good icebreaker. And you'll be amazed how many men will want to talk about this. And I mean, if I said to you, I mean, how many people will bring this up often, always in clinic? Have you got problems with erections? Is there anything you want to talk about? Most people, unless they're an andrologist who just talks about sex the whole time, will probably feel a little bit uncomfortable, and your patient is feeling uncomfortable, but we can't treat them unless we know that there's a problem. In our andrology clinics, we use erectile dysfunction as a marker for cardiovascular disease. So there have been a number of very big studies that have shown that when men start to have problems with erectile dysfunction, it's normally a marker for cardiovascular disease, and they can expect cardiovascular events within 5 years. So this is my point when I start saying to them, right, actually, you need to think about losing weight. You shouldn't be smoking. You know, we need to think about getting your blood pressure under control, any chest pain, so referring to a cardiologist as well. So it's a good marker for men. A lot of men don't like coming to the doctor, or definitely not coming to the hospital, and it's our opportunity to jump on them and try and improve their lifestyle issues. So we speak about erectile dysfunction, they fill in questionnaires. Is it psychogenic? And there's always an element of psychosexual issues. We need to know about their risk factors, we need to know about their hormones. As I said, do the early morning hormones, especially the testosterone. And then you need to know about the contraindications for the treatment. So very quickly, tablets that you might have heard about. So Viagra is called sildenafil. and Cialis is called tadalafil, and those are the two main ones that's available in the NHS. And so just to briefly kind of tell you about those two, so these drugs were identified as a treatment for angina, and so they were doing trials on these drugs. The men was obviously sent away, came back and asked, how's your angina, They all came through saying, well, the angina's okay, but my erections are amazing. And so they jumped onto this medication of, right, we finally have a medicine to try and improve erectile dysfunction. So Viagra needs to be taken on an empty stomach. So if there's food in the stomach, it won't work. So you need to remind men that an hour before they take it on an empty stomach, and it lasts for about 4 hours, which isn't great. It kind of ruins the spontaneity. Hang on a second, let me just take my tablet. No, we can't go to the cinema and have a hot date. It's not brilliant. Whereas tadalafil or Cialis, you take 4 hours before, and it doesn't matter whether there's food in the stomach or not. And actually, it can last up to 36 hours. So they take it on Friday afternoon, they can have sex on Friday night and sex on Saturday morning without having to think too much about tablets. It looks like it's much more expensive there. It's actually come off patent now, and the price is much better. And so these are medications which are readily available. They can get over the counter at the chemist. They don't even need a prescription anymore. They just need to be told how to take the medication. So men who come back to us and say, well, I took the tablet and it didn't work, you need to make sure, how did they take it, in terms of, did they take it on an empty stomach, did they take a license use, have they been buying it from some dodgy online? I'm sure my children love these adverts that keep on cropping up on TV at the moment about erectile dysfunction. They can get these drugs anywhere, and not all of them are the particularly good tablets. So make sure that they're taking it the right way, make sure that they're getting it from the right places. A lot of people will be a little bit nervous about taking medications, in which case there are adjuncts and alternatives. And so this is a vacuum pump. I think the vacuum pump is probably the least sexy piece of equipment that I hand out in my clinic, and I say to most men that I see, look, I'm not wanting you to think of this as a sexual aid. This is more about improving the blood flow to the penis in a kind of lose it or use it type mechanism. So you don't need to do this before sex, but 3 or 4 mornings a week, you use this as a vacuum pump device where the penis gets put in the vacuum, you pump it up, and it pulls the blood into the penis. It looks like they get an erection, you release it, down, and they go up and down for 5 minutes, 3 or 4 times a week. It's quite important psychologically that they feel they're doing this, and a lot of men will really be keen to do this because it feels like, actually, right, I'm trying to do something to improve my erections. But as I said, some people will just say, oh, this is just not for me. So how do they work? They work like that. So the advantages are, it's easy, they're not having to take anything, they don't get any side effects, but the disadvantages is quite cumbersome, that they're massive, and if you had young children in the house, it would be quite difficult to hide. It can cause a little bit of bruising. You'd have to come up with some amazing story of what it might be. It's for cooking or something. They explain it as a cold penis, so it doesn't feel like a normal penis. They don't get the proper glands engorgement, and they're not going to ejaculate with it. So lots of disadvantages, but I think if you sell it as a, look, this is an exercise, this isn't for making you get an erection to have sex, although many men do use it that way. It comes with a constriction device, which is a little bit like an elastic band, which is rolled down, so they pump it up and give themselves an erection, roll the constriction device, and it tries to retain the erection. And a lot of older men will use that very happily, but for my younger patients, I'll often say, look, don't think of it in that way. If men are worried about taking an oral medication that's not working so well, there is actually medicines that you can put directly into the penis, and these are available on the NHS as well. And so there's 2 different things. It's called a medication's called alprostadil. It's different to Viagra, but works in a similar way of causing vasodilation. It's a little pellet that they put down their flaccid penis. They rub the penis together as it melts, and then they'll get an erection direct from the penis. It can cause a little bit of pain and discomfort. Again, you have to think about it before sex, so it ruins spontaneity a bit. And you have to train men how to use it. But actually, it can be quite effective for men with mild erectile dysfunction. The biggest issue that we have at the moment is availability of all of these medicines is very difficult to get hold of, so they come in and out of stock. So if the Muse isn't available, so Muse is the one that's available on UCH, the next one is Vitaros, and Vitaros again very similar, but rather than a pellet, it's a liquid, so maybe slightly easier to apply. Again, they squirt it down their urethra. I have a lot of men who are like, oh my God, no, I just can't even think about it. Pull their wives or pull their partners in, get the partners to do it. The women or whatever, partners are normally less squeamish than doing it to themselves. The next one I'm going to mention really briefly, but obviously you'd be very nervous about giving an intracavernosal injection to a patient who gets priapism with sickle cell. With thalassemia, this can be quite useful, and this is intracavernosal injections. Now, I normally lock the door before I tell men about this because they want to run out screaming, but it is such an effective medication. It really is brilliant. So if I can convince them to let me give them the injection, they can see what their erection is like, they will change their mind completely. But most men are just like, no, I'm not doing that. So again, pull the partners in, get the partners to learn how to do it. It's very effective. The needle is really small. It's a little bit like a diabetic needle, so diabetics tend to be much more psychologically ready to do it. They inject their penis and they'll get a very firm erection within 10 minutes. One of the risks of these injections is priapism, though. So 4 to 5% of men will have a risk of priapism, and so we always need to tell men, look, if you get an erection that doesn't go away, cold shower, masturbate again, exercise, and if not, you come to A&E really quickly, where I'll give you another injection. So in your priapism group, you'd probably avoid this one, but your other medical patients, it's a very, very good medication. And then lastly, penile prosthesis. Who knows that you can have a penile prosthesis put in on the NHS for erectile dysfunction? You can, yeah. So NHS England have said that all men with end-stage erectile dysfunction are allowed a penile implant. Doesn't matter where they live, it doesn't matter, what's wrong with them or what caused the erectile dysfunction. It doesn't even matter how old they are. My oldest was an 84-year-old man. These men keep coming for help. And so penile prosthesis is put in via a surgical procedure. There's two different types of I keep pushing the wrong buttons, two different types of implants. One is a malleable, which is like there's no car people here, but like a Ford Fiesta, and the other one is a bit more of a Lamborghini, the inflatable. So the malleable is really simple, really straightforward, less risks. We will often put this in the acute situation in patients who have had priapisms for too long, and it's basically two rods that just sit in the corpora of the penis. If you think about those white bendy lights we have in clinic, it's that kind of mechanism. So they push it up when they want to have sex and put it down when they don't want to. But it's it's not brilliant. It doesn't make them as rigid as they'd like. Whereas the inflatable, you can see there's three different components. There's a little pump that sits in the scrotum. So if you were to really stare hard, you might think they had 3 testicles, and then the reservoir fluid that we hide in the abdomen. So all of that is hidden in the body. And when they want to have sex, they pump, and the pump takes fluid out of the reservoir into the cylinders, gives them a very firm erection. They still have an orgasm, they can still ejaculate, they can still have children. It's just men who are unable to get erections. So penile implants are absolutely excellent and very important for the priapism patients. So patients will say, does it feel different? Does it allow for romantic spontaneity? Well, yes, it's just pumping rather than taking a tablet and waiting a few hours. How will my penis look? So the big question is always, will it make my penis bigger? No, it will not. And in general, it will make it look smaller than it did before when you had an erection. So what we say to men is it's your stretched penile length. So if you pull your penis as far as it will pull, that is how big your erection will be. Whereas a lot of men will notice when they get a normal erection, the penis is actually much bigger than that. So many men will complain about loss of length. However, if you're not getting an erection and it's your only option, it's a good thing. But they always complain about length and size. Overnight stay in hospital, and will anyone be able to tell I have an implant? Well, with the malleable implants, if someone was a swimming teacher or worked with children, we might say that that's not appropriate because it might look like they have an erection quite often. So we will sort of recommend different types of underwears and things just to keep the erection down, whereas the inflatable, it disappears completely. So tiny little cut that we make on the penis, so just on the bottom surface of the penis, and we can get all 3 of those components, the abdomen, the scrotum, and the cylinders in there, and that's in with the implant at the end of it. To which if I was talking to a group full of urologists or andrologists, they'd all go, ooh, whereas you all look really unimpressed. Just to mention really quickly ejaculatory dysfunction. So it's really separate from erectile dysfunction, and you just need to tease it out from your patients. So premature ejaculation, anorgasmia, all sorts of different issues that they might be having, and it just involves really direct questioning, and again very happy to discuss in our clinic if you're not. There's a number of different reasons why men can get premature ejaculation. It's very common. As men get older, they will notice more premature ejaculation. And in terms of treatment, We'll try all sorts of different treatments. So there's a great spray called Stud spray, which you get from Boots, which is basically a local anaesthetic spray that you spray on the top of the penis to decrease sensation. You might recommend that they use condoms. We recommend stop-start techniques, vibrators, various different treatment options for these men. And just the last couple of slides, just to say that your patients who have come, through childhood, through adolescence and now into adulthood, it's really difficult to deal with adolescence, particularly when it comes to sexual dysfunction. And trying to take someone through childhood into an adult when you have a parent sitting there can be quite difficult as well. And what we try and do is we transition these children into the adult teams in a very gentle way, making sure that they have some time alone with us when mum and dad aren't sat in the room. There are a number of issues, I'm sure you see this with all of your childhood patients, not sexual dysfunction, but a number of psychological issues that would come with chronic illness. And because of those behaviours, risk-taking behaviours, drugs, smoking, alcohol, that can all make these symptoms so much worse. And it's important to be able to talk about it with these young people so they know that we're aware of it, we're here to help, if they start to have problems. So sexual dysfunction, incredibly uncommon, not just in your patients, but if we look at all men, so 40% of men over the age of 40 will have an element of erectile dysfunction. Although patients are often very shocked when they talk to me, I just say, look, it's a sign of aging. The older you get, the more likely you are to have sexual dysfunction. Sometimes that's absolute shock and horror, that they fully expect their erections to keep on working till 90, even though their knees, hearing, heart, everything else is falling apart. There's a number of late effects that we have in your patients that we're really happy to look at. UCH, we've got 18 andrology clinics per week, and so lots of people to be able to discuss all these different issues that your patients can have. There you go, whistle top. Oof, I'm sorry.
Thank you very much for that. Any questions? Over there.
You talked about overnight oxygenation being important in priapism. Is there a role for sort of regular sleep studies or checking for these patients?
Yeah, and there is a sleep study clinic. Both guys and UCH have had sleep studies, and they've looked at these patients and shown that people who have poor sleep have worse outcomes, and actually treatment with CPAP and oxygenation is an effective tool. It's expensive and it's difficult to get into the sleep studies. That's one of the biggest issues. Oh no, don't ask me.
Hello. Is there a sexual dysfunction clinic for the female patients as well?
Yeah, there is. So there's an awful lot of gynecologists at our hospital, and I'm sure throughout that we'll deal with this.
So if you see a
They might want to talk about like their sex lives as well.
Yeah. Yeah, absolutely. I mean, I think Vikram and I have kind of leaned on different factors here. It's just to say that all of this service is available. You just have to remember to ask your patients, because they might be very embarrassed to say to you, they might not know that it's available. But yeah, there are people desperate to talk to them about all the kind of dysfunction that they might come across.
Thank you.
Well, you can theoretically get a priapism of the clitoris. It is possible, but it's not something that we see that often. I think it's more likely to have issues with, hyposexuality, feelings about, poor body image, poor hormones. It's a little bit different. But yeah, libido is a big issue as well. No, I think if you start in small dosage and build up, so historically with the non-haemoglobinopathies, we start high and drop down, but in this group I would just start really low and then build up. But it actually is a treatment option for men getting priapisms, and that you're just trying to resync the whole erectile function. Yeah.
And we had to kind of
that.
Yeah.
So we're thinking on the right track then.
So every man who I ever say, well, we should give you a Viagra, thinks he's going to drop down dead and die, and that's because of media and press pushing about 15 years ago, and that's because the patients they started that out were angina and heart patients. So actually the only contraindication is people who are on nitrate medication, where it will lower their blood pressure and lower their blood pressure again. If they are very medically unwell, so if they struggle to do a flight of stairs, they might struggle to have sex, and so health and sort of exercising is important, but I would use that as my opportunity to say it's time to stop, getting fit and doing some exercise.
Yeah. One thing I would say, because there was a trial using sildenafil in sickle cell, wasn't it? But I think that was at higher doses. And they did get increased pain. So I think that put some red cell consultants off.
Yeah.
But certainly in my experience, prescribing it for the patient, it's exceedingly well tolerated. Start low and slow and then crank it up.
Cialis or tadalafil have a licensed 5 milligram daily dosage tablet, and for young people particularly, that one is brilliant. Yeah. Really low dosage. It's funding.
Philip asked online, can it be clarified if masturbation is a treatment for priapism? The NHS England leaflet states not to do it.
If you've got an erection, it's what we say is try and masturbate, try and have sex and see if ejaculation will make it better.
I think we all do the same, but he's just put a picture of it in the chat where it says don't do ice packs, don't have sex or masturbate.
Oh my God, don't do ice packs.
It will not make your erection go away. Yeah, so everything that we would say do, yeah.
And that's nice.
Yeah, can you put the link in the chat, Philip, for... Yeah.
But because certainly what we tell our boys is to star jumps, weirdly, is a popular exercise choice for a subsection of our patients, and also a warm shower. Yeah, that helps. But a warm shower. But ice packs, no thanks.
And also
so I think it's general information.
Okay, it's general information rather than red cell information.
Okay, I mean the other issues as well as cycling. We don't think cycling where maybe you're pushing a seat into your perineum, which might worsen. So cycling might be the exercise that I say not to. But yeah, running, sit-ups.
Don't get on the peloton.
Any more questions online?
No, shocked.
No, brilliant. Thank you very much.
Is this the...
Yeah. Pardon? Can I? Don't know. Can I? How do I do that?